Good evening, ladies and gentlemen. Welcome to our open discussion forum today addressing the COVID-19 vaccination. My name is Sibella Elong, a member of the Leoneans for Development family. SL40 believes that we are stronger when we pool our resources together, especially within our own community. Tonight, we have two phenomenal individuals who will co-host this important discussion for us. Our first co-host is Dr. Ivan O'Brien-Coker. Dr. Ivan O'Brien-Coker holds a PhD in chemistry and has worked as a researcher in an analytical chemistry in a number of institutions, including the Medical Research Council. He worked briefly at Zeneca before they became AstraZeneca, but has no current affiliation with the company. Dr. Ivan became very passionate about teaching young minds and transitioned into education. He is now in educational leadership as a vice principal of a London institution. Our second co-host tonight is Ms. Arlette Gobert, who is a business and finance graduate. For the past 2 decades, she worked as international luxury spa and hospitality director. Currently, she is on a consultative basis for pre-opening team productivity, a mother to one, a small business owner in the hair and beauty industry. Current interests are charitable work for Sierra Leoneans, hence the Sierra Leoneans for Development affiliation, and also working with women and young adults on holistic confidence and self-awareness. So without further ado, ladies and gentlemen, please join me in welcoming our co-host for this most important open discussion about the COVID-19 vaccination. Dr. Ivan O'Brien-Coker and Ms. Arlette Gobert. Thank you very much.
Thank you, Sibella. Good evening, everyone. Good evening, panelists. It's a pleasure to have you all here today, and also my co-host, Dr. Ivan O'Brien-Coker. We're discussing a very emotive subject today, which is a current issue. It's all over the news about the COVID-19 vaccine. Without further ado, I'm going to introduce 3 of our panelists. I'll start with Miss Alimatu Dimoniken. I've admired this lady for quite a while from afar, that it even urged me to send her a Facebook message quite a while back because I was enlightened by what she did. Alimatu Dimoniken is an award-winning leading women's and girls' rights advocate and a founder of A Girl at a Time on an online platform for young people working on SBGV. Currently, through her organization in Sierra Leone, she is focusing on the menstrual health education and support of adolescent girls as their latest project at www.girlatatime.org/get involved. The next panelist I'm going to introduce is Mr. Alpha Umarubari. Alpha Umarubari works as a clinical nurse specializing in research for nurses for the NHS in London. He has 15 years clinical experience, first in hematology and oncology and clinical trials before moving to hemophilia clinic trials in 2012. He has worked on a number of projects. Last but not least on my list is Dr. Mohamed Kamara. Dr. Mohamed Sori Ibrahim Kamara is an emergency medicine consultant at Tameside and Glossop Integrated Care NHS in Greater Manchester region in the northwest of England. He is a frontline medic and he's got loads of experience to bring to the table today. That's the 3 panelists. I'll now hand over to my co-host, Dr. Ivan O'Brien-Coker, to go through the final 3 panelists.
Thank you very much, Mrs. Arlette Gobert, and thank you very much, Mildred, for that wonderful introduction. Ladies and gentlemen, it is a pleasure to have you all here. can I firstly remind you that we are recording, so if you do not want to have your face in camera, please take the appropriate action. Can I also remind you to have make sure you have your device on mute so that obviously your voice doesn't cut through when we have the panelists speaking. We have actually people from the USA, from Sierra Leone, and of course the UK. And we're very, very pleased to have so many of you here because we have this very important issue that we need to address. And the issue is the reluctance or the hesitancy of a number of Black people in particular with the vaccine. Now, obviously, there's a lot of reasons why people are not comfortable taking the vaccine. So what we're trying to do here is to address as many of them as possible. We are very fortunate to have some excellent experts here. We have a pharmacist, we have a general practitioner, we have researchers, we have a consultant, etc. So without further ado, I'm just going to briefly outline the three panelists who have not yet been introduced. Now we have Dr. Harris Faulkner, who is actually a general practitioner. He's actually one of the COVID vaccination leads in his practice area and a member of the Bexley Local Medical Committee. He's an excellent musician, he's an organist, he's a wonderful trumpeter, and he's a choir director. Ethan is a man who always means business. He's the son of the Prince of Wales School. We have Mrs. Mildred Johnson Bundu-Kamara, who's a registered hospital pharmacist for over 25 years. She's a clinical director of pharmacy and medicines optimization at the Maidstone and Tunbridge Wells NHS Trust in Kent. She holds a master's degree in strategic healthcare management and leadership and performs other lead roles, including chairing the Trust Drugs and Therapeutics Committee. Her most recent and ongoing work with the COVID-19 vaccine was published in a prestigious health service journal in January 2021. Mildred is very passionate about reducing COVID-19 vaccine hesitancy in the BAME community by sharing evidence-based information and her experiences. Our third panelist is a religious man. Sheikh Bemba Ibrahim Conte attended the prestigious Graduate Islamic University of Medina in Saudi Arabia and graduated with a BA Honors in Theology and Law. He also holds a master's degree in Islamic Studies from the Muslim College in London. Sheikh Bemba has been an imam and Islamic consultant at North Brixton Islamic Cultural Center, which is a popular Sierra Leonean mosque in South London. He's also an Islamic consultant at the Anur Masjid Mosque in West London. Ladies and gentlemen, these are our panelists. I'm going to hand you over now to Alex, who's just going to take us on to the start of the discussion.
Thank you, Ivan. Okay, the first speaker tonight is Miss Alimatu Dimoniken. She has a presentation on social context with emphasis on girls and women and the wider community. Alimatu, would you like to start, please?
Thank you so much, Dr. Ivan, and thank you, Aletta, for those really, really kind words of yours. It's a pleasure to be here, and I'm also looking forward to this incredible panel discussion, and I think it's one that we should be having currently at this present time of this pandemic. And like you rightly said, I'm an advocate for women and girls, and we have seen, you know, COVID has been hard on everybody, to be honest. But what we have seen through the work I do in the UK, working with a leading agency working on the area of domestic violence, we have seen how hard COVID has been on ethnic minority, particularly Black, African and Asian women from the Bangladeshi community. So according to the UK National Domestic Violence Helpline, or the abuse line itself, there were 25% increase in terms of online requests for help since the lockdown. And we saw in April last year, just less than a year now, or almost a year now, the Victims Commissioner highlighted for England and Wales that there was over 16 women killed within the first 3 weeks of the pandemic. And that hasn't stopped. We have seen even more. I believe by the end of this week, we're going to have another data coming out showing the impact that actually the lockdown has had. We know coronavirus poses a real threat to society in terms of sustaining livelihood and the survival of women and girls. We've seen an increase of domestic abuse in Africa, the continent where most of us have come from. But in the UK, Black women are 4 times more likely to die in pregnancy in the UK. So we're already seeing the pandemic itself, COVID itself, is affecting the health of women and girls. And I'm so glad that we have the experts who are going to highlight or expand on that a little bit. And then also what we have seen, Black pregnant women are 8 times more likely to be admitted in hospital with COVID. And we're also seeing that there are delays for Black and ethnic minority women making access for health. And that also include men as well. Men and boys around mental illness, mental health are also delayed in accessing services. So again, I would like to hear what the experts have to say. Socially, we are now seeing the impact that that is having on children since the first week of term. So since 2005, according to recent data by the Princess Responsible Business Network, so we're now seeing what this means for economic development and growth in the UK and elsewhere. It says since 2015, there's been an increase in proportion of people from Black and ethnic minorities background reporting, witnessing, and experiencing sexual harassment and bullying in terms of their role within the employment. So we are now seeing within the NHS, we know of social injustices and social inequality already being highlighted as one of the key factors why so many Black and ethnic minorities have died as a result of COVID. Finally, we know through the main refuge services or refuge agency that deals with the national response to domestic abuse in the United Kingdom, reported 700% rise in calls in the single day. In one day, there were 700 people calling in for help. Majority of those obviously were women, but we're also seeing a lot of children calling out for help. Women and girls are not safe during this pandemic, and it's evident through the killing of, just last week, we had Sarah Everett, who was murdered by a police officer, and that's ongoing. We have seen endless cases of domestic abuse, which are not reported to the police, which is why we are asking communities in the UK, particularly from the Black and ethnic minority, to take up the vaccine, because we know a healthy community will protect its women and girls, and in turn might also protect boys and men. And so it's so important for us to engage in this dialogue today and learn to see what the good is or the benefits we're going to gain from the pandemic. So I hand over to yourself, Alette, and Dr. Ivan. Thank you very much.
Thank you very much, Ms. Demonican. We really need to focus on the effect of this virus on our women, because it's really, really important. It is very, very important. But we need to understand a little bit more about the disease, and who better to tell us more than somebody who lives and breathes research and knows about the COVID disease in depth. And that is Mr. Alpha Umar-Obari, who's now going to talk to us about the disease. Mr. Alpha Umar-Obari.
Thank you very much, Dr. Ivan Obaran-Coker. Thank you very much to Sierra Leone for development for inviting me to speak on this so emotive topic, which I think has ravaged quite most of the BAME community more than anything else. Just to put it in context, I was fortunate to be seconded, deployed to another trust to help out. I wasn't, my specialty is not respiratory, but we had to help turn patients over from a prone position onto their front. And in that hospital or ward alone, I have never had the Quran so read ever in my life. So you could hear it for the 11 hours, the Quran being cited from start to finish. So obviously, this virus has caused severe devastation within the BAME community. So what is this virus? I can just start by giving you a small understanding of what the two terms mean, coronavirus and, can you see my slide or no?
Not at the moment.
Not yet, okay.
Not yet.
Hold on.
I think you may need to share, are you sharing the screen?
Yes, I'm going to share the screen now. Okay.
Whilst we're waiting, can I just say...
yeah, is there.
Okay, thank you.
Okay. Coronavirus, a large family of viruses, just to put it in context, which may cause illnesses in animals or humans. There are several coronaviruses that are known to man, and they're known to cause respiratory infections. They range in severity from the common cold, as we all know, to ones which emerged around 2002 and 2012 in the Middle East. One of them is in Southeast Asia, the SARS-CoV-1 that caused SARS. And 2012, we had the MERS-CoV that caused MERS in the Middle East, and that's a respiratory disease as well. And in 2019, which we all know, in Wuhan, in December, a similar SARS virus emerged. It was first called a novel coronavirus. After the understanding of the genetic sequence of this virus, this was changed in January 2020 to SARS-CoV-2, which is severe acute respiratory syndrome coronavirus 2. Viruses, as I don't know how many people know this, but they come in all shapes and sizes. They can be spherical, they can be cylindrical, they can have a polyhedral shape. However, the coronavirus itself has got this spherical shape with spikes poking about and creating a crown-like appearance. And it's called corona, just to make people understand, because of the corona you see after a total eclipse. Just above there, the picture that shows you what total eclipse, that's where the name originated from. And these viruses can have contents inside them. For those with medical or science background, it's called RNA, or in some cases DNA. But in this case, the coronavirus has an RNA inside. And viruses, as we know, they cannot divide, they cannot replicate themselves. So what they do is they find a way of entering the host and injecting whatever is inside them and hijack the machinery of the body itself and produce copies of themselves. That is how viruses divide. In the case of coronavirus, here you have this coronavirus, and there is a lock on the cell surface. This lock, for those who want to know the science, is called an ACE2 receptor, but it's a lock. And the coronavirus, as you saw from the previous slide, has these spikes, and these spikes here bind to the lock on the cell surface and allows it entry into the cell. And in the cell itself, it uses the machinery of the cell to produce copies of itself and then goes back out and infects other cells. What is funny is that, I don't know how many people know this or why the symptoms are so variable. These locks, called ACE receptors, can be found in the lungs, it can be found in the GI tract, in the gut, it can be found in the kidneys, and it can be found in blood cells. Just the other day, I was looking at a scanning electron micrograph that shows what COVID has done to some cells of the airway, human airway here. They purposefully injected one cell or a few cells, inoculated them in the lab, in vitro. And after about 96 hours, you had about 3 million units formed per one cell, so per one culture. So you can see how coronavirus can divide within a short space of time, infecting all the body organs with those structures, which I said to you that these locks are present in. Here, the symptoms can be variable. Obviously, it targets first the respiratory system, and it can be transmitted by droplets, contacts of foam-iting surfaces, or door handles, doorknobs, whatever you control, lift buttons. So before you get infected, and people who are infected can be of two types. They can be symptomatic, they can be asymptomatic. And as we know, the incubation period for this virus is between 2 to 14 days. And majority of people, about 80% of people, as you know, are asymptomatic. And they have the disease and they recover without needing treatment. So the spectrum of clinical response, it can be asymptomatic or you die eventually. So, and the symptoms you get will be respiratory distress, GI distress, renal failure, or dementia. I put the word dementia because these receptors also, these locks are found in neurons and glial cells in the brain. If around 15% may get severe disease, including pneumonia, older people and those with underlying medical problems like high blood pressure, heart and lung problems, and diabetes or cancer have had increased risk of severe disease. You can go also to a really sick or critical stage. At that point, about 5% of the people infected can be at that level. And these may lead you to have septic shock or have multi-organ failure or respiratory failure. Overall, the fatality rate is higher within the older people, 75 years and above, which you can see from my slide and data present so far. It's about 11.6%. And also in the younger age group, it's about less fatality rate, about 0.5%. The symptoms may be variable by age and may include the following. In adults, you may have a continuous cough lasting more than an hour, maybe 3 or 4 episodes within 24 hours. You may have a high temperature, you may have a loss of smell or loss of taste in some instances. Other symptoms being reported, these, by the way, are not exhaustive because as more data comes in, the more symptoms we get added to this list. So being fatigued, shortness of breath, having headaches, sore throat, lethargy, aching muscles, myalgia, which is called myalgia, or runny nose, or sometimes diarrhea and vomiting. In children, the symptoms are slightly different. It could be fever, which happens in the majority of cases. About 70% of children present with fever. About 39% or so have cough and nausea and vomiting. And about 30% have shortness of breath. In most or almost all the children who have tested positive have got gastrointestinal symptoms. That's one of the ways you will know that they have got a coronavirus as well when they present. Complications of COVID, obviously.
No, it's wrong. Yeah, it's wrong. We get a link.
Can you please mute your mic, please? If you're not presenting, can you please mute your mics? Thank you.
With the complications of COVID, having mentioned all the keys which the virus can unlock with the receptors being present in these body systems, you can see how the complications it can lead to. Venous thrombosis, heart and liver kidney problems, neurological issues, coagulation, your clotting cascade develops a mind of its own, respiratory failure, multi-organ failure, and going to septic shock. Having said that, if you recover from COVID, now the new data coming in is what you see people who've recovered from COVID, they have what you call long COVID, which is this list I've presented here to you. But obviously we are adding to this list as we get more information given the novelty of the virus. With all, having said all that, people who are asymptomatic makes up about 80% of the population, and these people would be regarded as carriers of the disease. And if they are carriers of the disease, that means they can infect other people without knowing. My final thought, why you need to vaccinate. Between 30 to 50% of people who are clinically asymptomatic despite testing positive, and that is quite worrying, because if they are, and that means the virus has a chance to mutate if these people are not vaccinated, and when their numbers increase and number of mutations increase, that makes it difficult to have effective treatment and definitely a cure, possibly. And without further ado, I'll hand back over to Ivan just to give you a brief overview of the virus and its implications.
Thank you, Mr. Barry. Alex will take it from here.
Okay.
Thank you, Mr. Barry, for that in-depth synopsis of how COVID manifests itself and evolves within the cells. That was enlightening. We'll now move on to our third speaker, who is Dr. Ethan Harris-Faulkner, who is going to talk on the impact of the disease in the BAME community. Ethan, it's over to you.
Thank you very much, Arlette, and Ivan and the Sierra Leoneans for Development Organization for this very useful opportunity to share with our people what exactly happens and how COVID is affecting us. My talk will be on the impact of the COVID-19 disease on the Black, Asian, and minority ethnic populations, basically the BAME population. Just bear with me a second. Now, the UK census in 2011 revealed that the BAME population was about 4.5% of the English population in total. And the Office of National Statistics estimated that by the year 2016, we would have got up to 15.4. I'm very interested to know what the census that has taken place this year will show. I wouldn't be surprised if our percentage share has increased. We also know that the BAME groups were diagnosed with COVID a lot more than the white ethnic groups. And these disparities of the representation in the population were very marked. For instance, the Black and ethnic minorities had 649 per 100,000 males having the disease and 486 per 100,000 females. This when compared to white ethnic groups of 224 per 100,000 males and 220 per 100,000 females shows that we were more than doubly affected. From the infection goes hospitalization. And the Intensive Care National Audit and Research Center showed that there was an overrepresentation of Black and ethnic, the BAME population needing intubation and ventilation in the hospitals. So we were a lot more represented in terms of being critically ill, 15.2% Asians, and 9.7% Black and African and Caribbeans. From the hospitalization, what happens next? You either got better or you die. And unfortunately, Black people from Black and African descent were 3.5 times more likely to die than their white British compatriots. The Pakistanis were 2.7 times more likely, and the Black Caribbean 1.7 times more likely to end up in death. This is information obtained from the Institute of Fiscal Studies, which reported on death in English hospitals. This event of deaths in the BAME group being greater than in white ethnic groups was the opposite of what transpired in the years before the pandemic. This is very, very important. Prior to this pandemic, more white ethnic groups died than the BAME population. During this pandemic, that has switched. We represented, proportion-wise, are dying a lot more. Which brings us to the next question. Why do we have this marked disparity in population? There are several factors. One of them is the regional factor, which shows that London is the most represented in terms of incidence of the disease and deaths. And that is greater than in the Northwest, which followed by the Northeast, the West Midlands, and the Southwest of England. Basically, the deaths in London from COVID-19 were 3 times greater than deaths in the southwest of England. We also noticed that you had a lot more deaths in the urban as opposed to rural areas. One thing that is very marked in urban areas is overcrowding. Overcrowding means close proximity for people, which, as we are aware, intimacy increases transmissibility. The BAME community also has, the BAME population also has the multi-generational households. We have several generations living in the same household. This is very marked, especially in the Asian community, where you have grandma and grandpa living with mom and dad, living with the children. Sometimes you even have aunties and uncles. That unfortunately means that their bubbles are big, yes, but within a big bubble means an increased chance of having the virus. Areas of deprivation also resulted in increased incidence of the COVID vaccine. The greater the deprivation, unfortunately, the greater the disease, and subsequently, the greater the death. The occupation exposure, this is very important and very relevant with regards the BAME population. Frontline workers with public-facing roles. Who are the most represented? We are healthcare workers, bus and coach drivers, security guards, chefs, taxi drivers, sales and retail assistants, lower skilled workers in construction and processing plants, workers in social care. Frontline roles, public-facing roles means increased risk and increased exposure to the disease, increased risks of contracting the disease and subsequent death. We also noted a poorer health outcome when you were infected. This again is very prominent in the BAME population. People who are not born in the UK may have language barriers. A language barrier means they are more hesitant to seek help. They eventually end up seeking help when they are far down the line. And this is not only for COVID, this is for diseases in general, which means that they are more susceptible to far worse outcomes. We also have the good old law, your immigration status. When your papers are not up to date, you do not feel comfortable seeking help, and which means that you are more prone to stay at home until you are at death's door before you go to seek the help, which, if sought earlier, would have resulted in positive outcomes. And there is also the unconscious bias from professionals, because professionals can, even without acknowledging it, have a tendency to downplay certain health conditions, because yes, the person's language might not be very, very fluent and they might not be able to express themselves properly. You also have the homeless. There are quite a few people who are homeless or who sofa surf. And the homeless man is one who has a lot more things on his mind than seeking his health improvement. So poor health outcomes when they are infected. Next, we come to comorbidities, that is the other ailments, the other conditions which might affect somebody's outcome. One thing that is very noted is the presence of diabetes. We have a greater number of diabetics in the BAME population as opposed to white ethnic groups. So Asians, for instance, have 43% representation, and black groups are 45% represented when it comes to diabetes. We also have hypertension that is more noticed in the Black African and Black Caribbean groups as opposed to ethnic groups. Obesity. These three things play a very major role in how the COVID affects the individual. So high incidence of these pathologies means a negative impact on the BAME group. This was something I found which scared me. It says that the Office of National Statistics reported that comparing deaths between March and May of, I think it's March 2014 and May of 2020, it was noted that there was a 4.5 times higher increase in the number of deaths in 2020 from people born in Central and Western Africa. So this is massive. This is massive, showing that deaths this year are 4.5 times more than deaths in 2014 and 2018 from people born in Central and Western Africa. Concluding, let me just state again that the BAME populations are more at risk from COVID-19 infections. Therefore, it is very important that we all get vaccinated as soon as we are able. Thank you very much.
Thank you very much, Dr. Hayes-Faulkner. It is really, it's actually quite telling that we have this spectrum from patients being, well, people being asymptomatic all the way to people dying. And I think one thing which Ethan presented, that before the pandemic, we had a lot more white people dying than people from the BAME community. And during the pandemic, this has reversed. I think that's actually it's quite poignant for us to think about. I remember last spring in 2020, many of us would have heard of somebody close to us, somebody that we know who passed away from COVID. And of course, we all remember the shock that we felt. We all remember how scared we were. We all remember when, during the very first lockdown, we were walking along and you'd see somebody coming towards you if you're going for a walk, and you'll cross the road because you don't want to be near them. Because we realized how serious this was, and people were dying that we know about, people that we loved. We were praying for a solution, fervently praying for a solution. Well, we have what might be considered the beginnings of the solution. We have vaccines which have been developed by scientists, and now they're being made available to us. But of course, some of us, many of us, are still hesitant. I should make the point that all of the panelists have taken the vaccines. The vaccine is the solution. Now, it's not going to end COVID tomorrow or next week or next month, but at least it's going to take us to a better place. We have somebody who's in the front line, Dr. Kamara, who is a consultant in emergency medicine. He's been working day in, day out during the course of this pandemic, saving lives. We're very fortunate to have Dr. Kamara, who's going to tell us more about the vaccines. Dr. Kamara, over to you, sir. Dr. Kamara? Okay, I'm not sure if Dr. Kamara can hear me, or you're on mute.
It's on mute, Ivan.
Dr. Kamara, I believe you're on mute. Can you unmute your mic, please?
All right, now you've unmuted me. Thank you so much.
Yes, lovely.
The other thing you need to do is probably allow me to share the screen. Where are we? Let's see if I can put that up. Right. Thank you so much for that introduction. And hopefully we can get this going. Oh, come on. Right. So, thank you so much. I've been doing these talks for over a year now, and I think it's important to remember that in anything you do, especially when it comes to the vaccine, it's important to put the case out there for everybody to be able to know what the pros are and what obviously, the cons are. And then obviously allow the person to go into it and with an open mind, make an informed choice. So talking about the vaccine, I think it's important to understand what is a vaccine. Now, a vaccine is a kind of a foreign body. It's an antigen that you actually put into human beings or animals in order to help them fight against the disease. Now, the vaccine contains a dead or a weakened version of a microbe, which is a foreign body that would have entered the body by one way or the other. It helps the defense of the body to recognize this foreign body and destroy the living foreign body or microbe during, a future exposure to this kind of illness. So you have it for the first time, you develop a kind of defense against it. And so whenever you get exposed to it, there is that recognition, there is that mechanism which recognizes it, and then obviously helps you fight against it. So it defends you against it, and that's what the vaccine does. It prevents, but it doesn't treat the illness. And I want this to be clarified from the very beginning. It is preventative and not curative. It's absolutely vital for people to understand that. So if people think when you've had the vaccine, that's it, I'm cured. Please, please, please do not be confused by that. It prevents the disease. Right. The vaccine contains, as it is, the antigen, which, as I said already, is a killed or weakened version from a virus or a bacteria, if you like, which then trains the body to recognize and fight the disease when we encounter it in the future. It also, like everything else, has got some adjuvants, some things added to it, which then help to boost the immune response, the immune system to respond better. In a way, it helps the vaccine work better. And then, of course, like everything else, you have to preserve it. Some of the vaccines, as you know, have to be thawed, have to be defrosted from 60, 70 degrees to normal temperature, like 20 degrees or room temperature. That will take some time. So you need to have preservatives to ensure that the vaccine stays very effective. And of course, you have to have stabilizers, which would help you in terms of the storage and transportation. But how do vaccines work? Now, as you can see, the weak or dead form of the vaccine or the antigen, i.e. the bug that goes into your body, is actually introduced into the body, and then this sparks a response from your immune system, your defense, that helps you develop antibodies that are remembered by this, this body of yours, so that every time you get exposed, the antibodies will help you fight off this germ when it comes back again. So that's how it works. Vaccines obviously are very safe because they get thoroughly tested, to make sure that it doesn't cause any untold harm to the human body. It takes so many years, as we know already, for it to go through trials and tests, various rigorous tests, in order for it to be found to be safe. And once the vaccine has been approved, it will then have to be monitored in terms of long-term side effects, in terms of complications that may arise in the short term, in the medium term, and in the long term. And this, in the UK, we're proud to say we have the MHRA, which is the Medicines and Healthcare Products Regulatory Agency, that helps us in maintaining that. So if we look at why we need the vaccines, now people are wondering, well, hang on, why do I need the vaccine? I've survived so far, it's a year. Think again. As I said, because of the vaccines, you have 20 million people, 20 diseases that are actually, you are protected against. So 20 illnesses, you'll find out as we go on. It saves up to 3 million people every year. That's a big, big thing to do. Imagine that. So when you have 2 million people saved because of measles, then you'd understand why I'm talking about this. Look at what we have in Africa. I have people who are relatives of mine, who are friends of mine, who are people that I grew up with, that do have crutches. Some of them do still have their calipers. But thanks to the vaccine, polio has been eradicated from Africa. Yeah? And recently, 2014, 2016, the massive outbreak, epidemic of Ebola, within 2 years, between 2014 and 2016, there were 2 vaccines that were developed, because of Ebola. So we are now obviously more equipped to tackle it should we have any further outbreak. But look at that, you have 4 different types. You have the live ones, which are attenuated, the weakened. You have the inactivated ones. You have the recombinant ones, which are conjugated. And then you have the toxoids. Now, if you look at them, you'd see that the live ones include the MMR, which mothers or parents will know about. The rotavirus, which we know is very prevalent in the winter, causing diarrhea and vomiting. Smallpox, as we know it. Chickenpox, which we know in childhood. And yellow fever, which is very prevalent in the Sub-Saharan region. You have the inactivated ones, which we know include vitamin A, hepatitis A, the flu, which we live with every year, and of course, polio we talked about already. And the big one, rabies, which is very, very difficult to treat in Sub-Saharan Africa because the mortality is quite high. If we don't have the vaccine against it, we're in trouble. The conjugated ones are the Haemophilus influenza type B. And then you have hepatitis B, which we all know about, the human papillomavirus, which causes cervical cancer in our young women, our young children, our young daughters. So they have this vaccine. And now they're vaccinating the boys as well because they know full well that the issue of developing the cervical cancer doesn't just rest with the women or the female, it's also coming from the boys. So the boys themselves are getting that. So you got whooping cough, which we call pertussis in medicine. There's that 3-part vaccine you get as well. And people who've got cancer, people who are immunocompromised, they know about this pneumonia vaccine because that's what will take them out. So they have to be vaccinated against pneumonia. Again, if you are going to any of the crowded places in the military, going for Hajj, going for pilgrimage, you will definitely need the meningitis vaccine. The same applies to the shingles in the elderly. Our elderly people, elderly population definitely suffer with this big time, and it causes problems for them. Some of them end up with long-term pain on their sides and whatever is affected. And of course, you have the toxoid ones, which are diphtheria and tetanus, which we know there are 5 injections. Now, you ask the question, if I take the vaccine, do I have side effects or not? Well, like everything else, we've been taking the flu vaccine every year, annually. We know about the side effects. The side effects are short-lived. They will last maybe for a few days, and thereafter, that's the end of it. Now, we have things like low-grade fever that has been reported. Some people report dizziness. Some people reported headaches. Some people reported pain in the injection site. And, of course, some redness, And the severe, long-lasting side effects are very rare. We've been hearing about blood clots, but as we say, if I go into the details of how blood clots are formed, you'll probably be surprised that you can't just blame it on or put it squarely on the shoulders of the COVID vaccine. Far from that. It's a long process, but we'll talk about that if we need to. Apart from that, the vaccines are continually being monitored for us to be able to detect any rare side effects. So that brings us to the history of the vaccines we're talking about currently, which is the mRNA vaccine. So if someone worries about this thing going into their DNA and changing their DNA and making them infertile and all that, that is not true. These are messenger ribonucleic acid vaccines, so messenger RNA vaccines. They were discussed in literature, believe it or not, in 1990. So it's not as if it's something recent. This is 1990. This is over 30 years, as you can see yourself. The clinical trials of the mRNA vaccines definitely these were deployed in the outbreak of Zika virus in the South Americas, and of course rabies, as we know, influenza, and the cytomegalovirus illnesses. It was first tested in the human beings 7 years ago. Now, they're preferred over the traditional vaccines because of their safety, because of the half-life for it to be decomposed. It could be regulated, and of course, its immunogenicity can be regulated down. Of course, they're very efficacious and they're easier to produce. So this is a big question. I think this is where the hesitancy comes in. A lot of people have been asking, well, hang on. We've had illnesses lasting 60, 70, 80 years. We've not had a vaccine yet. We have COVID. And here you are, you're telling me within 12 months to 18 months, the COVID vaccine has been developed. What is that about? Well, this is the answer to it. As you can see, normally when you start a trial, you start it with the animals, make sure that it's fine. And if you get nothing negative, then you move on to the first stage, which is phase 1, where you have just a few people. And then that gives you the response that you need, which is a far better one than you'd expect. And then you go on to the second phase, where you have a few more hundreds. And then if that doesn't give you any dangerous or any untold side effects, you move on to the third phase, where you have hundreds more volunteers, not mandatory volunteers. And once you actually can then collect all the evidence and of course the data that you need, then you can then get the seal of approval. That's where you get that green tick. But that is not the end of the story, because you need then to continue to monitor the side effects, and that's it. That's what you do normally. Here, you'd have to go through the ethics committee. Sometimes it's a long, laborious process, tenacious. You can say what you want, and then the funds dry up, and you don't have the money, you don't have the permission to continue. But with this, it was a pandemic, and it is a pandemic still. And of course, the world would have been at its knees if at all the lead scientists had not come together and decided, we will wipe away the bureaucracy, we'll wipe away the red tape, we'll pump money into it, and then obviously see where we go. And of course, any of those that find out whatever it is that is a positive thing, they all share. And in that way, they collect the evidence, and you would see that in record time, this was definitely approved, and we're all benefiting from it now. We'll talk about that later, but this is just a brief example of what is going on. You can see for polio, as I mentioned earlier, 60 years, for us to get a vaccine, as you were. Ebola, I mentioned, between 2014 and 2016, we were able to, get 2 vaccines. But before then, we were really struggling. For 15 years, we couldn't get anything. SARS, we talked about already, and a previous speaker talked about the SARS, which is the COVID illness type 1, and now we have type 2. And MERS, we have the one coming from Saudi Arabia, Dubai, and the Middle East. That is even more, I say, lethal, if you like, or, mortality is quite high. But up till, as I speak to you, 6 years, they're still struggling. But with COVID, all of that was moved off, money was pumped in, and obviously they developed it, in good time. So when you do have the vaccine, these vaccines do have a way that you have to administer them. The first dose would actually be on day 1, and so you administer it intramuscularly in the muscle of the arm. And then you start to develop the immunity, not on the same day, but on day 12. So by the time you get to day 21, where you need the second dose to top up the first one, again, it goes into the muscle of the arm. And by the time you get to day 28, that's when you know you'd have been 80-90% covered. Okay, so that's how it works, as it were. This is me, as you can see. These are the 4 types that we do have. They're all known to the world as we know it. There's the Oxford one, which we're proud of, which is British. We have the Moderna one, and we have the Pfizer one, which we all know about. And of course, the one that is less or least heard about is the Sputnik from Russia. But they do have one thing in common. They all require 2 injections each, apart from the Johnson & Johnson one, which you'll find out about. But if you look at it, the Oxford and the Gamaleya one, they have less taxing problems in terms of storage and transportation. Whereas with the Pfizer, you'd have to thaw it from 60, 70 degrees minus to bring it down to a temperature where it's actually doable and can be received by the human body. But think about it. If you do have that, you have a batch, you have to have used it within 5 days. Other than that, it goes to waste. So therein lies the problem. You need to think long and hard which one you have. And nobody can choose. Again, as I said, there are 6 that we know about. Johnson & Johnson is the only one that has got 1. The rest of them have all got 6. But look at how telling this is. This is what it does. When you take the vaccine, you get 100% protection from the severest form of the disease, 100% prevention of death. But as you can see, they vary in the efficacy between 70 to 90, 95%. But one thing they have in common is that 100% prevention of hospitalization and, of course, death. So that's how it works. I don't want to go into the details of it, but it's definitely an RNA virus. It's not a DNA virus. Therefore, it doesn't go into the nucleus. I think my learned colleague would actually deal with that in detail. But that's how it works. So the DNA vaccine will go into the nucleus, but this is an RNA, so it's actually just around the cytoplasm, and then after a few days, it's mopped out and then taken out of the system. So these are things that you need to know about before you make your mind up. Why is that important? Because we're talking about hesitancy. And it's important to remember that our DNA, which they're saying Bill Gates is going to microchip and is going to put trackers on us, is definitely false. Yeah? You want to remember that those of us who are Muslims, who are Jews and whatever, who do not eat pork, well, it's been cleared that these vaccines do not possess any pork or any gelatin. Yeah? There's no evidence for anyone who's vegetarian to be concerned about it, because they're all been proved to be halal. You know, one thing you must know about is that the companies that do produce these vaccines are all indemnified from their governments. Yeah, and they have been rushed through because of the fact that the red tape and the bureaucracy and the ethic committees were all out, and of course you then ended up with the money being pumped into it. Just the AstraZeneca, you had over 40 million pounds just pumped into it. So it gives you that. I don't want to play this video because it's too long, or if you need to, we'll play it. This is just some of the things, a list of the things that I actually have been asked, you know, genetic modification, cutting corners, how you can get the COVID from the mRNA vaccine, and of course, it causes infertility. But I can tell you safely that 200,000 babies have been born this year. So if you talk about infertility, I don't think that supports that. You know, I'll stop so far, and I'll probably hand over to my other colleague. Thank you so much.
Thank you so much, Dr. Kamara. That was very, very insightful and very, very detailed. And it's really important that you've already started touching on some of the myths that, you know, obviously lots of people have, which is obviously why we have this vaccine hesitancy. We're now going to ask Mrs. Mildred Johnson Bundu Kamara, who's going to talk to us about some of the evidence, recent evidence on the COVID vaccination. Mrs. Mildred Johnson Bundu Kamara.
Thank you. I'm just sharing my slides. Thank you very much. Hi, can everybody see my slides?
Yes.
Slide one. Thank you. Right. So thank you all, everyone, for coming. I see that we've got a large number of people online. So what I'm going to do, the first thing I'm going to ask us is to sense the temperature. So we're all here because we want to hear about the vaccine, and we're all concerned about the uptake and the hesitancy amongst our communities. So I'm going to try and be very interactive for this part. I'm going to try and be very interactive for this part.
Can you mute your mic, please? If you're not the presenter, can you please mute your mic?
So what we're going to do is we're going to do a survey, and we're going to do a survey.
Can you just hold on? Can I ask that if you've entered, ladies and gentlemen, if you've just entered, can I please ask that you mute your mic now? Thank you.
Can you hear me?
Yes, we can. Thank you.
Okay. So we're going to do a survey. It's just two question survey. The first one is about, have you had the COVID vaccine? And then the second one is, are you likely to have the vaccine? Okay. I'm going to move over to Femi. So Femi, could we put on the survey? I must stress that it's anonymized, so nobody is going to track the results to anybody online. Just two questions. It's really important for us to know how we're willing to take this vaccine, or if we have had a vaccine. It'd be nice to know. We've got over 120 people on. So I'm kindly asking you, we'll do this now before you hear my evidence, and then we'll do it again at the end of the program after we've answered your questions. So over to you to vote. So the first question is, if you've had your COVID vaccine, yes or no, that's straightforward. If you tick yes, you don't need to go to question 2. If you haven't had your COVID vaccine, we want to know how likely you are to get the vaccine. So we want to know if yes, you've actually made up your mind that you're going to get it. If no, or if you're on the fence, you're undecided, you don't know if you're going to get it. So if I give you a few seconds to do that, please. So just press the right answer, the answer that you want to prefer on your screen. Thank you. Are we all able to submit? Are we all able to submit?
I think everyone's on mute, so I think most people have now submitted.
Okay. Kemi and Femi, how are we doing?
Yes, most people have submitted. I think we may have a few strugglers or people not willing to. The first question was answered by 79 people, and the
Fantastic.
second
That's
was
amazing.
answered by 82.
Okay, brilliant.
Okay.
Thank you. Okay, I'm going to move on. So I'll just take this off the screen and okay.
Do you want the results or can you all see them?
No, we'll do it at the end.
Okay.
Okay, so we'll do the poll again at the end and then we'll know what the differences are. Thank you. So Femi, I'm going to go back to my screen now. Can you stop sharing the survey so I can continue with the screen? Thank you.
Yeah, you should be good to go.
Okay, thanks. I'll do it in a minute. Just taking a while to come onto full screen. Okay, so the next slide is just to recap what my colleague, Dr. Ethan Faulkner, has said about vaccine hesitancy, just to give you some stats about it. We know that the disease is quite severe in the BAME community. He's clearly articulated that just now in a beautiful presentation. We are more likely to die of this disease, but yet we are the more hesitant group in the society in taking this vaccine. This vaccine has been out and we've had people of high status in the country. So we talk about the Queen, we talk about the Duke, we talk about Boris Johnson, you name it. All the people there at the top have actually gone and they've had this vaccine. So if it wasn't safe, my just basic question is, why would they want to take it? We have a high hesitancy in the BAME community, as high as 72%. Whereas the willingness for the white folks is at 82%. We see this trend not just in one area. If you look at the areas that are deprived, the most deprived areas where you would find people of Black and Asian community, the uptake is low. In the more affluent area where you get all the rich people, you get a higher uptake as well. Again, in the healthcare sector, when you go in hospitals, you get a lot of uptake in white staff, and the Black and Asian staff, you get a lower uptake. So this trend in low uptake amongst the BAME is not just in one area, it's across the board. The rollout of the vaccine has been actually very, very remarkable, and it's been very successful, one of the best in the world. I think there's only Israel and United Emirates that is ahead of us. If you, I am really, really proud of the work that's going on for everybody. And I published something in the Health Service Journal, just here for you if you want to have a read, just highlighting the efficiency and the swift uptake of the vaccine in my organization. So that's a nice read for you. Let's talk about the dashboard. Where are we now today in the UK? So we've seen about over 28 million of first doses. That's a lot of vaccines on the arms of people, 28 million plus. This data was on the 22nd of March. What we're seeing, because of the vaccination, there's a decline. If you look at all the squiggly lines here, the red one, the blue one, the green one, you're seeing a trend in reduction in incidences. And that is because of the vaccine. We're now seeing some effects of the vaccine in the population. So the number of people who are being admitted has come down over a 3 months period. The total number of deaths we're seeing now has come down. The cases are coming down. It's not over yet, so let's not be fooled. It's really not over yet. The cases are coming down, and also there is this perception that if Joe Bloggs gets vaccinated and I don't get vaccinated, well, then I'm protected. That is not the case. By relying on others to be vaccinated will not protect you. You have to have your vaccine to guarantee that you will be protected. So the common question that most people would like to see the answers to are, does the vaccine protect against COVID infection is one. Does the vaccine reduce the severity of the disease? Does the vaccine reduce the risk of death from COVID disease? Is the vaccine really safe? That was one of the highest concern in some of the studies that have been done. People are worried about the safety of the vaccine. So what I'm going to do now, very briefly, I'm going to show you about just the details of three trials. These are key trials. I know Dr. Kamara has spoken about the vaccine itself. What I want to look at is, where are we now? We've come a very, very long way. So what is it in the population? What is happening in the society? We've seen over 28 million people being vaccinated already. What is the evidence now that all those people have been vaccinated? So the first study I'm going to talk to you about briefly is a study in healthcare professionals. It's called the Siren Study. It was started in December when they started vaccinating. So what they did was they looked at the incidence of COVID infection amongst healthcare workers who had been vaccinated, and they found a really encouraging effectiveness of the vaccine. It was effective by 72% after just the first dose of Pfizer. So people were being protected. They were not getting the disease at a rate of 72%. The next one is, it was a bigger study. It's called the World Study, and it was done in the UK as well. They recruited about 7.5 million adults over 70, because as you remember, they started vaccinating the 80-year-olds, the 70-year-olds. So this was the first population that they studied. And what this is telling us is that the vaccine is effective, both of them. After the first dose, it's effective at 70%. So at 70%, you're having that effectiveness. It's preventing you getting the disease at that rate. In addition, there is a very, very important aspect of the reduction in hospitalization. So if you get COVID and you get serious disease, you have to go into hospital. So if this vaccine is reducing your hospitalization, it means that even if you get the disease, you're not getting very severe illness. So it is reducing your hospitalization. So the one statistics I want you to take away today is that after a single dose of either the AZ vaccine or the Pfizer vaccine, it is going to reduce it's going to prevent you getting into hospital from COVID by 80%. So it will prevent hospitalization for COVID infection by 80%. And then when you combine it together, the hospitalization and death for either vaccine will be reduced by 80%. So that's an impressive statistics from a scientific angle. The last one here is called the nationwide study. So we know in Israel, they've done a lot. You know, the majority of the population is now vaccinated. So when they started, they looked at 600,000 people who had been vaccinated, and they matched those with another 600,000 that were not vaccinated. So what they were looking for, they were looking at the rate at which the vaccine prevents those groups getting COVID. They looked at the rate at which it prevents them getting into hospital, and it looks at the rate of death between the two groups. So a group that has had the vaccine and a group that didn't have the vaccine. My goodness, the results were impressive. So we're seeing that the effectiveness of the vaccine is at 92 to 94%. It's preventing the disease. And then going into hospital is preventing it by 87. So if you get the disease, it's preventing you being so critical to get into hospital by 87%. And then your risk of death is reduced by 72%. So this is one of the very, very outstanding trial results in the population. So lastly, for me, is around the issue around AZ vaccine. I would like to reassure you here before I go. And this is around the AZ vaccine. We know that a number of countries in Europe, they withdrew the activity of AZ vaccine. They actually put a pause on the vaccination program. And this was because there was some history or talks around clotting. They were worried about clotting happening after AZ vaccination. The MHRA have reviewed this evidence. As a chief pharmacist, we get constant directives from the MHRA, from the Public Health England, from NHS England on this issue. And the report that we've got is they've reviewed this evidence in the UK, and there is no evidence of clotting in the vein. So this is deep vein thrombosis that you may have heard of. It's a natural occurrence in the population. So 1 in 1,000 people will have a clot at any time in the population. There is another rare clotting in the head called sinus thrombosis, which it occurs in less than 1 in a million. So it's a very, very, very rare clotting that could occur in the brain. Again, this clotting occurs in the natural population. So even if people don't have the vaccine, if you want to study them and observe them, you will get that clotting at that rate, less than 1 in a million. So this is happening in the normal population. So there is no link at the moment that any of the vaccine can cause this, because they have not seen an increase in these incidences in the group that are taking the vaccine. So most of the reports are mild side effects, which you've heard from other speakers before. And because of these, a majority of this side effect, because they're mild, the MHRA said that we should continue to vaccinate because the benefit outweighs the risk. So we're seeing that we can reduce our risk of COVID by 70 to 80%. So I am urging you to reconsider, having heard from the wealth of speakers today, please consider this vaccine when you are called upon to receive the vaccine. I'm looking forward to answering your questions in the next part of the session. So thank you. Thanks for listening.
Thank you very much. Thank you very much, Mrs. Mildred and Johnson Bundukamara. Now, we have there 3 up-to-date studies, now giving very, very important information that we should take on board, because it's very important that we realize what the scientists are doing and new evidence which is coming to light. If your child ever says to you, why should I study science? Well, you have the answer here, because we have a lot of science, we have a lot of maths, and you've been exposed to quite a lot of scientific words today. Now, obviously, some of you are very, very familiar with science, but I hope you're able to follow the way our presenters have dealt with the issues. Now, obviously, we have a number of scientists here, but we have somebody from a religious background. We have Sheikh Bemba Ibrahim, who's an imam who's going to give a religious perspective. He's also obviously officiated over funerals, and he's just going to share some of his thoughts with us. Sheikh Bemba Ibrahim. Sheikh Bemba, are you there? Okay, while Sheikh is organizing himself, can I just ask that if you do have questions following on from what our presenters have actually presented to us, can you please type them onto the chat? We have one of our coordinators who will be channeling the questions to the hosts. So please continue to type your questions, and Sheikh Bemba will now give his presentation. Sheikh Bemba, are you on mute? I can't see you. I'm not sure whether you can.
Yeah, I can't see him, Ivan.
Right, okay. Well, okay, right. If Sheikh Bemba is not here, then I think we're going to transition on to the question and answer session. I mean, there are lots and lots of questions which I'm sure people have. We've had obviously quite some detailed explanations, but of course, you know, many people might have some burning questions which they want to obviously touch on. And I'm sure we would want to amplify some of the information which our presenters have given to us. So I'm going to ask Alex to just take us over to the questions and start with just posing some questions to our panelists.
Okay, I would just like to apologize. Obviously, when you're virtual, you do have some problems sometimes. So the internet was playing up a bit. Okay, the first question I'm going to throw to the panel is, what exactly is the meaning of efficacy in relation to vaccine and the population? Who'd like to take that one?
Can.
Fantastic, Mildred, go for it.
Yeah. So efficacy is just a term, another word for effectiveness. So it's just how effective will the product be when you take it to humans. So in terms of this vaccine, I've just demonstrated the effectiveness of the vaccine. We know that it's around 70 to 80% after the first dose. And that could go up to 90% in the case of the Pfizer vaccine. So it's how effective it is. The effectiveness could be for any reason. So in a trial, you would have, they would have like the primary outcome. So what is the main outcome that they're looking for? So in the COVID trial, the main outcome that we're looking for is the effectiveness which is how effective it is to prevent somebody catching the disease or getting the disease actually. Presenting with the disease, and then effectiveness as well. The other bit outcome could be what is the rate at which it could reduce me getting into hospital. That means looking at the level of severity of the disease. So that's what it is. It's just an effectiveness.
Thanks for that, Mildred. Ivan, would you like to ask the next question?
Yes, I'm going to direct this question to Mr. Barry. Mr. Barry is involved in clinical trials quite a lot. I wonder if you can just talk us through a little bit about his experiences with clinical trials, just so it's clear for everyone to have a full understanding. And then he may want to just link us on to what, Dr. Kamara has already mentioned about the rapid production of the vaccine. Mr. Barry.
Okay. Thank you, Ivan, for the question. It's very interesting. It's one of the things as well I've heard so much in the social media noise about the hesitancy in taking the vaccine. Clinical trials is a process by which drugs or medication or any product fit for human consumption are made. It could be any type of medication. In this case, is the COVID vaccine. Now, before what probably the public doesn't know is that from the discovery of this coronavirus, knowing that it was a novel coronavirus, scientists talk to each other. They would have emailed each other, sent each other samples. They have conferences where they meet and set up networks. Obviously, with the Human Genome Project giving us that technology to decipher the genome of the virus, it was easy for them to picture out how exactly what type of virus is this and how to make something against it. So they will try first in the clinical trial to do in the background clinical trial research, where they will look at animal models or tissue samples and infect them and try and get some data from this, knowing that, yes, we've got a positive data here to show it is effective. So now we need to go to the next stage, which is first in man, and that's the phase 1, which Dr. Kamara was talking about. They will do phase 1, and phase 1 is just to check to make sure it is safe in man. And phase 2, where they will look at also the dose and the efficacy of it, as Dr. Mara put on his slide. And then phase 3, where they look at the larger number of people taking it, making sure it works. But in this instance, you had, because it's a pandemic, money is no object. Just as Dr. Kamara alluded, every government will throw in money at it, trying to come to a solution. So to make sure it doesn't paralyze the whole world economy and take us into whatever the 1930s was. I wasn't born then. But then after, because you go through phase 1, phase 2, phase 3, they normally do them in sequence. But now these were run parallel. So it was quicker for them to collect the data. Additionally, you had with the world statisticians, almost everybody, they are looking at the numbers, making sure it does what it says on the tin. And exactly the first question, is it efficacious? And indeed it was. So these are the processes as to why the vaccine was produced so quickly in this instance. And I would employ people not to have any doubts in it, because if I can flash my card, just like you said before, I've had both doses.
Thank you, Mr. Barry. I'll hand over to Alex now.
Oh, hi there. I think this one probably is more suited to Dr. Harris. I've already had the COVID-19, so I wouldn't benefit from the vaccine. What would you say to someone that says that to you?
My response would be this: when you have the disease, as Dr. Kamara mentioned, you develop antibodies which help to protect you. The disadvantage that COVID has is nobody knows how long those antibodies are going to last for, because with time they might wane, and the fewer antibodies you have, the more prone you are to the disease, which is where the vaccines come in. Because the vaccines help your body to produce antibodies, and hopefully antibodies that might last for a bit longer. Even that at the moment is still being analyzed. So I would say my advice would be, better the devil you know than the angel you don't know. If vaccines work for long-term protection, I would rather trust the vaccine which is going to ensure within limits that I have continued protection than just depend on my natural immunity which might not last for very long because the jury is still out. Hence the need to get the vaccine.
Thank you, Dr. Harris. Ivan, would you like to ask the next question, please?
Yes, I mean, we're talking about the vaccine, but I think maybe it might be useful for someone to share what exactly is in the vaccine. What are the ingredients of the vaccine? Can someone take that? Who'd like to take that?
I think Mildred.
Yeah. Okay. So the vaccine, each vaccine, as Dr. Kamara said, you've got the excipient. So the main thing would be for the mRNA vaccine, is the mRNA, the code that actually is going to be translated when it gets into your body. So you've got the mRNA sequence, I would say, of both vaccines. They're presented in a different way. So in the Pfizer vaccine, it is wrapped around a fat tissue, and then in the AZ vaccine, it's actually in an adenovirus. It's in a weakened virus. So, but they both have that, which is the actual active ingredient, so the mRNA sequence. So you got other things like when you do a vaccine or any product, you need to have things that would make sure the product is stable, so the product doesn't degrade, so the product doesn't come out of suspension. Just think about if you're in the kitchen and you're making flour, you're mixing flour and water. If you leave it to stand, what happens? The flour will sink, isn't it? And the water will stay on top. So in the same with products, you have to make sure when you're making these pharmaceutical products that you have that consistency. So you need to put certain ingredients in it that would enable that. So things like potassium chloride, you've got the agents that might prevent coagulation of the product. There is an interesting thing. There's also water for injection. There's sucrose. There is also an interesting thing. One is in the Pfizer. It's called PEG. PEG is called PEG is called polyethylene glycol. It's called PEG for short. And what it is it's a substance that's found in various medicines like laxatives as well. It's just an agent, again, that helps to give the product stability. But sometimes PEG can cause allergic reactions in people. And that is why I think you may have heard that the Pfizer vaccine can cause more allergy reaction. And you would find that if somebody's got an allergic reaction, they would say, okay, you might be best getting the AZ vaccine. Instead of the PEG, AZ vaccine has got another thing called polysorbate 80, which is slightly different from that. So in a nutshell, you've got the active ingredients and you've got all these other things that either helps to suspend the product and to keep it stable.
Thank you very much indeed. Dr. Kamara, you did mention, you talked about the number of vaccines. I wonder if you could amplify for us the different ways in which the vaccines work. You talked obviously about the mRNA vaccine, and perhaps you might want to amplify, the process by which the mRNA vaccine works, as distinct from the other type of vaccines. Dr. Kamara? Is Dr. Kamara there?
Yes, I am. It would have been better illustrated on the slide
right,
that I showed. It's easier because all it is, the mRNA vaccine, as you know it, does not in any way, shape or form enter the nucleus. And you know the nucleus is where you have all of the characters embedded, all the genes and the rest of it, the characteristics of it, So it doesn't. All it does is a messenger. It goes around the cytoplasm and then it gets mopped up after it's done, finished with its business. In no way is it entering the nucleus to change the DNA. It's a messenger RNA vaccine. So its way of operation is quite different from the DNA one. And it's important for people to remember that in no way does it enter that nucleus. Therefore, it doesn't touch the DNA at all. There's no chance for it to alter it. but it would have been better illustrated. If you want to, I can show the slide again and you see for yourself what it is.
Thank you, Dr. Kamara. I think it's a really important point to note, because obviously many people have seen on social media that this vaccine can alter our DNA. Obviously, it's good to have the scientific perspective that is not true, absolutely not true. Thank you so much for that, Dr. Kamara. Can I hand over to you now, Alette?
Yeah, sure. Another question we've got that has come in: can I get vaccinated against COVID while I'm currently sick with COVID-19? Dr. Kamara, would you like to answer that, please?
Yeah, I mean, as I say, I think the guidelines are clear that if you have been confirmed to have the virus, and to the extent whereby you are afflicted by it and maybe you are hospitalized, you are not eligible to take that vaccine until there's a lag period of 3 to 4 weeks.
Okay.
Secondly, if you were treated with monoclonal gamma antibodies or whatever they call them, you're not eligible to take that for the next 90 days. And I think that's why, if you would have been following the world media, you'd see that Donald Trump received that and therefore wasn't eligible for his vaccine until by the time he was leaving office in February. So that's the thing. If you go to any of the vaccinating stations and all that, or wherever they put up the tents and you have to go, they would ask you simply, have you had any flu-like symptoms recently? That's a very standard question. And if you say you've had it within 1 week or 2 weeks, just like you've had, if you went for the flu vaccine, they'll tell you the same thing. Have you had flu recently or not? And if you say within the last 2 weeks, clearly they'll say, well, you have to have a lag period before you can. Otherwise, sometimes it can cause problems for you. So the lag period between having the COVID-19 symptoms and all that, that would probably bring you to hospital, is 3 to 4 weeks. And then if you had any treatment, including the monoclonal antibodies, you definitely would be 90 days.
Fantastic, thanks. You know, that leads me to another question. Having said that, how is the coronavirus different from the flu then? How would you differentiate the two? Good.
They actually have, it's interesting, in my other talks, I talked about it. People think this is different, but you have 4 types of these, viruses. You have the alpha, the beta, the gamma, and the delta, the subgroups. The alpha is what actually is the flu virus, and the beta is where you have this coronavirus. As I say, with the world as it is knows 7 of them. This is why it's not surprising that people think it's just a bad dose of the flu. Because when you look, I've got another slide where you have similar symptoms. You have allergic rhinitis, you have malaria, as it were, in the Sub-Saharan region. Yeah, you have the common cold, and you have the flu. They're all, and of course the COVID we're talking about, they're all very similar at the very beginning, but they have distinguishing features. And sadly, as we all know, COVID-19, the symptoms are still manifesting themselves to the extent where even the children sometimes present with bruises on the toe. I remember a patient came to me and had a bruise on the toe, and it's all on the screen. I saw it, and we all thought, well, what's that? Maybe there was domestic abuse or maybe child abuse or something. And it turned out that was what we call chilblains on the toes. So this child, when they were tested, came back positive for COVID. So that's one form of it. That's how it manifests. The symptoms are never ending because you keep hearing about them, and therefore it is difficult to distinguish one from the other at the very beginning. But suffice to say that COVID has got specific symptoms, which if you have them, not necessarily exhaustively all of them, but you are possibly looking at someone who may well not have the symptoms. Asymptomatic, as they call them, super spreaders. But then you have the ones who have the symptoms in varying degrees. So the flu can be very, very close to the COVID-19 symptoms. But then when you do the test for flu, you will definitely be negative. And of course, when you do the test for the COVID-19, you'll definitely be positive. That's one way of distinguishing them. But of course, the severity is one thing that also makes it very confusing, because 2 to 3% die, whereas with the MERS virus, you have up to 30%, 35%. So you could actually tell that you don't necessarily have to have all of the symptoms. Once you get the symptoms, you need to self-isolate and then test yourself. And that way you can then distinguish whether one or the other is what you're afflicted with. I don't know if I'm making any sense.
Absolutely.
Yeah, I think you're crystal there. Ivan, would you like to take the next question, please?
Yes. I'm going to direct this question to Dr. Ethan Harris Faulkner. Dr. Ethan, I know you're a man of God, and obviously you're a scientist. Now, some people say, why do I need a vaccine if I have God to protect me? I wonder what would be your response to that?
My response will be this. If we believe that God made the earth and all that therein is, then we should believe that it is God who made doctors, it is God who made scientists, and it is God who gave them the ability to create these things to help his people.
Can you please mute your mic? Thank you. Go ahead.
So if that's being the case, I would say I personally believe that God Can you hear me?
Okay, Dr. Faulkner, just hold on a minute, please. Can you all just check if your mic is on, and please mute your mic now, please. Thank you. Okay, go ahead, Dr. Faulkner.
Okay. So if we all believe that we have a common saying in Creole, God no de come up can down for can see and do what you need. He has given us the ability to get things done, and I believe that were he to come down, he would be more than happy to give the positive tick to the effects that man is doing to help his fellow man.
Thank you. Thank you very much, Doc. Doc, just a follow-up question. I mean, someone sent this question saying the survival rate for COVID is actually very high, so therefore they don't need to take the vaccine. I mean, that's a common thinking amongst people.
Well, that again is risking the draw, because what proof do you have that when you get the vaccine, you will survive? So that when you get the virus, you will survive. Because there are certain known risk factors, like which I mentioned earlier, like you being diabetic or having cardiovascular disease or being obese. But there are certain people who are known, well, who have not been identified as having any underlying factors, who still get rarely sick, and some of them do die. So I would advise somebody to rather be safe than sorry. If you have the vaccine which reduces your susceptibility and vulnerability to the virus, then my advice is for you to use that avenue.
Okay, thank you, Doc. Alex?
Thanks for that, Dr. Ethan. I wanted to ask this because a lot of people increasingly have been asking, why was the vaccine produced in such a record speed, whereas other vaccines for other deadly diseases such as malaria, it took quite a number of years for it to come to fruition? Mildred, would you like to answer that?
Myself.
I think you need to unmute.
Thank you. The host was trying to unmute me. Thank you. Before I answer that question, I just want to add to what Dr. Faulkner has said about people not wanting to take the vaccine because they want to play Russian roulettes here. There's also the issue around long COVID. So people do get the disease, they get better, but they never recovered fully. So you might need to go and research about long COVID and what the symptoms are. Really, really bad. You end up with neurological problems. You're always tired. You can't contain yourself. You get eye problem, loads of different things. So just be wary about that and just take notes. It can be debilitating, even if you recovered sometimes. Okay, my question around the question again.
A few people have mentioned that how come the vaccine has been manufactured in such a record speed, whereas in other vaccines, it has taken years to come to fruition?
Sure. So with the COVID, remember when we had the pandemic, we definitely haven't had this sort of thing. Well, not in my lifetime, not in your lifetime too. That's one thing. So there was a lot of focus worldwide in the problem. As one of the presenters said, Mr. Barry, the COVID, the Sars virus, is not a new virus. So it's a virus that the scientists, they knew about it very well. They had a similar virus in 2012 and in 2002, I think. So they knew the virus. The general nature of the virus is quite similar to the one, the COVID SARS-CoV virus at the moment. It's quite similar. So they knew about the structure of the virus in general. So when this pandemic occurred, the scientists already had that background information on the virus, and they all put all their efforts together in different parts of the world. Rather than manufacturing the item, the vaccine in a sequential manner, they had certain areas in the preparation of vaccine. One country was focusing on one area, another country was doing the other bit. So in a normal trial, you would do phase 1, phase 2, and phase 3. It didn't happen this time. They were doing it in parallel. So whilst phase 1 was going on, phase 2 was going on at the same time. So it meant that overall, it took a shorter time to reach the end stage, but it doesn't mean that they cut corners by any means. Everything was done, but it was done in parallel. So they reached the end goal earlier than would normally be in a normal situation.
Okay, thank you very much. There's a question here, a question from Ethel. Ethel says, I understand there's the third vaccine, Moderna. Is this now available, and is it as effective as the previous two?
Moderna is not, MHRA requirement. Moderna has been approved by the Medicines Regulatory Body, but it's not available just yet in the UK. So personally, I don't have any experience with it. I don't know if the others in the panel have got any experience with it.
No, I'm saying
Moderna is, as you say, not available. The two that are available are definitely the Pfizer and the AstraZeneca. Now, Moderna is more in the Americas. That's where you'd hear about that. And of course, we know about the Novavax and the Johnson & Johnson, which differs from the rest because it's just one shot, and they're hoping. One thing I wanted to tell people is to understand that we have probably sidestepped the issue about the variants. So if people are thinking that once I've had the COVID and therefore I don't need the vaccines, well, I tell you what, you count yourself lucky, because now you have over 10 variants, and you think that if you actually survived or maybe avoided getting one, you probably would be so lucky with the other 9 or 8. Be very mindful of that. Just think about it. Yeah, if you were lucky the first time, you might not be so lucky. And remember, the other ones are far more faster spreading, far more, if you like, difficult to tackle, because the vaccines we have, you might not even know whether they would be effective against those variants. So what I'd advise you is, as I say, a loaf, that you have now, remember, half of that is better than having nothing at all. Because remember, you might not be so lucky. I can tell you, I know people who've lost their loved ones 2 days apart. Yeah, this is important. And we are the worst affected ethnic group. Therefore, we need to be in the front line, queuing for this thing. So when your chance comes, please, 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 and pretty please, go for it, because you might just be saving your loved ones. If you are lucky you are asymptomatic, it doesn't mean you haven't got the illness. It doesn't mean you're not passing it to your loved ones. Would you want that on your conscience? I doubt that.
Thank you, Dr. Kamara. Dr. Kamara, there's another question which I think would be useful for you to shed some light on. I mean, it's with reference to the age, the disparity in deaths amongst the older people and younger people. I mean, somebody's saying we've referenced the ONS report, but they're noting that obviously most of the deaths are amongst the older population. So why should somebody who's young, where there's a very, a lower chance of death, why should they be taking why should they take the vaccine when they're least likely to die?
Yeah, there is young and there is old. I think the data we have so far excludes the children, but I know the youngest to have died was a 5-day-old. Yeah, that's because they had underlying problems. The problem we as the BAME community, I don't think we take care of our health situation as we should. We're not very, very health conscious. As my learned colleague said, we're the ones in the front line. We're the ones that are bus drivers, you know, the ones that work 2-3 jobs. Yeah, less sleep. It makes you vulnerable. It reduces your immune response. So you don't know if you have any underlying heart problems because maybe it hasn't affected you. You don't know if you have any problems that are there that are yet to be diagnosed. So if you say only the older people will die, well, look at what is happening. Yeah, there's a lot more people that are being affected now, even in their 30s. So do not look a gift horse in the mouth because you will live to regret it.
Thank you so much for that. Yes, Mildred, go ahead.
Just wanted to add to what the doctor has said. There is a study that was done in Manchester. So it looked at the age group of the population, different groups, so Caribbean, Africans, Bangladeshi. So they looked at what age group would you classify yourself as being in poor health? And 40% of the white population said they were in poor health at the age of 60 and 70. Do you know what the age was for Black people in poor health? It was 40 and 50. In the Bangladeshi community, it was 31 years. So what they're saying is a 60 to 70-year-old white man has the same health status as a Black man who's 40 to 50, and is the same as a Bangladeshi person who is 31 years old. So when you talk about COVID doesn't affect young people, we need to be careful as Black and ethnic minority, because we can be young, but our body is not young. And there is a study that showed this.
Thank you. I'm going to direct this to Ms. Demonican. Obviously, we have, we're concerned about women's issues, and obviously there's been some talk about infertility in relation to the vaccine, and obviously whether people who are pregnant should have the vaccine, and whether people who are breastfeeding. I know obviously you're not a clinician, but I wonder if you could just share some thoughts on some of the information which you're getting in relation to women's issues in relation to COVID. Ms. Demonican?
I think we need to unmute her.
Oh. We unmute Ms. Demonican, please.
Thank you so much, Dr. Ivan, for that question. I think I covered it in my opening speech, that we have Black women at 8 times likely to die during, 8 women are more likely to go into hospital admitted for COVID. We know COVID highlighted a lot of inequality in health. And as Dr. Kamara has already highlighted, it could be poor nutrition. It could be them not accessing health, because majority of the time, like the previous speakers have said, perhaps because they're working or they're on low income or living in very poor, deprived neighborhoods or overcrowding housing, social housing situation. There are many factors. And in fact, COVID has actually, apart from the clinical side of things or the medical side of things, it has also highlighted some social inequality. And this is why it's so important, because if we cannot hold on to anything else that would protect us as a community, particularly with our women and girls, because again, when people die in sort of a pandemic, we saw with the Ebola crisis in Sierra Leone, there were more women who died because they were on the front line. They cared for the sick. They went to work because they needed to bring some money home. And in the UK, majority of our community, the Black and ethnic minority, sadly have single female households, which are already strained as it is. There's less income coming into the home, perhaps more children to feed. And if a mother passes away, I think there were several cases of women, mothers who actually died of COVID. There was a renowned case in Reading, which is now a serious sort of case review for us to look at what errors had been made, because she actually was a nurse as well and died of COVID, and there were failings in that aspect. So there are many areas for us to look at. In the case of pregnant women with COVID, just as Dr. Kamara said, there's guidelines, and obviously the NHS would let the midwife who's providing care to that mother to know whether this is the right time for that mother to go and have the vaccine taken, which is why it's so important for us to protect those very vulnerable people. Just as we would with our 70-year-olds, we need to also protect our communities who are mothers, perhaps pregnant women, people with things like sickle cell anemia, people with things like other hereditary illnesses, because again, we have some vulnerabilities, and sadly with our Black and ethnic minority communities, it's very difficult for us to admit when we have illnesses, such as mental illness. We're now seeing how exacerbated mental illness and well-being has become a huge problem because we're isolated, we're in a lockdown, not many people to talk to, and sadly, there were lots of single men living on their own without a partner to tell whether they're not feeling well, they have nobody to talk to, and we're seeing how that is compounding the psychological well-being of so many of our community members, which is why we really want people to take up this vaccine. If you cannot take up the vaccine, we have the experts here, and ideally perhaps you all have to share your contact, because again, people are shy to go in and talk about, because at the onset of the pandemic, one of the things that perhaps I believe as a social community advocate and somebody working within my community, one of the onset of the issues that we had at the onset was misinformation. People were saying, oh, it's better for us to maybe boil lemon, chew ginger, you know, do the herbal stuff. We saw how that panned out in countries like Tanzania. So many of their leaders gave that misinformation because they felt that as African people, this was the best course of action. Sadly, that is not the case because people have died, and we will continue to die if we play ignorance, if we play lack of understanding of what the importance is, which is why I'm so delighted to be here. And I think it would be important for people in this meeting today to be those very advocates. Let us all go back to our homes, speak with our community members, particularly those who are the vaxxers, who are saying, oh, it's not for me, I wouldn't get the COVID, I don't need the COVID, I've already had COVID. We've heard from the doctor. We have variants of the virus now. The South African variant, we have one from Mexico. So it's going to be, we're going to live with COVID. This is now going to be part and parcel of our day-to-day living activities. So we need to work around that.
Indeed, indeed. Oh, thank you so much. Thank you so much, Ms. DeMonica, because it's so nice the way you've just rounded up where we are. I mean, we do have lots of questions, and we know we can carry on this discussion probably till midnight, and there'll still be more questions coming. We've come to the end of our time, I'm afraid, ladies and gentlemen. And I know we do want to ask more questions and we want to carry on, but I mean, we have to keep to time. So thank you so much to all of you for your participation. And we're now going to just transition to the next part of our program, which I'm going to hand over to Alex to just link us on to.
Before I link on to that, I'd like to thank the panelists as well for taking time out of their busy schedule. It's greatly appreciated. Now, I think we're going to have two social media influencers, Mr. Lamin Kosto-Derami and Mr. Abdul Wahab Sise, DJ Little, to say a few words. Are they here, Ivan? Are they around?
Derami, are you able to start now? We just have about 2 minutes. Mr. Derami, are you here?
Hello, can you hear me?
Yes, thank you.
Oh. Abdul, what has to say here?
Go ahead.
That's right. Apologies. Good evening, everybody.
Good evening.
Good evening.
I want to say welcome once again. I want to say what a massive opportunity to be around such eloquent leaders in terms of healthcare. I've been gained in some energy, some knowledge, and some fascinating wisdom as well. So I'm coming from an IPC point, but I will not be speaking as infection prevention and control in my professional capacity today. And as it stated, I'm just going to speak as a social community influencer personality. My take is, I think I made a quick note on the 3rd of January this year. I think I had my first vaccine, and then on the 24th, which was Wednesday, I had my second vaccine, and I had to say I'm still here. I feel great, and I'm only 45 years old, and I feel privileged, and at the time I also feel guilty, where there are other people older than me who are probably likely to should have received the vaccine. However, based on my healthcare profession and I'm in my professional line of work, I've been given the opportunity to receive the vaccine, and I've grabbed it with both hands and feet. And for my brothers and sisters out there, whether you're younger than myself or especially those who are older than myself that are in the position to receive the vaccine at this point and are continuously creating either hesitancy or reluctancy. There's another thing that to do with hesitancy. There's also a word which is not floating around quite often, which is reluctancy, or what you will call anti-vaxxers. Well, I will put those in the same category. I will say, think wisely with all the wisdom which has been shared tonight by all aspects of professionalism. I would have no doubt but to go out there. Or alternatively, if you're in a position to speak to a loved one, a family member, and who is finding themselves in a state of doubt or hesitancy or reluctancy, use your opportunity as a young person within health and social care to convince either your parents or your relatives to go forward. Because one of the key things which we're going to say here just before I round up is coronavirus is not going to go away. It's not going to go away. It's going to be here, and we are going to have to live with it, and we are going to have to cope and work around it. And in any way, we're going to have to find ourselves to survive with it. And the best way is to be in the front line to ensuring that I have been one of the first to be protected.
Thank you so much for that. Thank you so much for that.
Is that okay? And if I can just round up to the general public is, when you're out there, just because you feel that you've received both vaccine or one single vaccine, remember to still follow the government guidance and the strict restrictions, ensuring that you're still following social distancing, wearing your face mask or your face covering as appropriate.
Mr. Abdul, I have to say we have to thank you for that. Thank you very much for that.
Thank
we
you
now
very much.
need to ask Mr. Lamin Costa-Derami to say his 2 minutes. Just give us 2 minutes of his time. Mr. Costa-Derami. Mr. Lamin Costa-Derami, are you here?
I saw him because I let him in.
Yes, I know. I did see him. Are you there? Maybe you need to unmute your mic. Are you there, Mr. Costa-Derami? Okay. Well, it might be that he's not around or he's not able to speak, in which case we'll move on to the vote of thanks by Mr. Leslie Gibson. Mr. Leslie Gibson, are you there?
Yeah, he is.
Okay.
Thank you, Dr. Ivan. Let me start off by saying what a privilege it's been for me to have been able to witness such a...
Quickly, Ivan, I'm sorry. Can I just quickly, I think we've kind of like skip one or two things. Mildred need to do the poll results quickly. That doesn't take too long. So after that, we can probably jump to Sheikh Bimba, and then Mr. Gibson can do the vote of thanks, please. Sorry about that. Yeah, so we'll have Mildred's poll, Sheikh Bimba, and then we get Mr. Gibson to do the vote of thanks. Thank you.
Thank you, and sorry about that. We did promise that we were going to do the poll at the end so that we can know the difference. So, yes. Are we ready to vote? Brilliant. Have we all managed to vote now? Hi, Femi. Have you seen the numbers?
Yeah, there's still quite a lot of people still to vote.
Okay.
We've only had a very few who voted.
Please cast your votes, really important, so that we know if our lovely presentation, as you've been saying in the chat, if it has worked. So are you likely to have the vaccine? Have you changed your undecided to yes? Thank you. How are we with the numbers?
The numbers are quite high at the moment, Mildred. It's looking at 87%.
So, okay. Obviously, I can't see it. Do you want to summarize what it is at the moment?
Have you had the COVID vaccine? Yes is 59%, no is 40%. Are you likely to have the vaccine? Yes is 89%.
Fantastic. That is amazing. Fantastic. Undecided?
Undecided, we've got 11%.
11%.
No is 0%.
Okay, no, that's wonderful. Do you know what the first score was, if you still have that first one?
No, Mildred would have to check that later.
Okay, thank you. But honestly, really thank you, everyone. That's amazing. If we have increased this to 89%, that is amazing. So thank you so much. Thank you.
Thank you very much indeed for that. Thank you. We're now going to have Sheikh Bimba, who's going to say something. Just to give us a few minutes. Sheikh Bimba, are you there? Sheikh Bimba, we are waiting on you now. If you're there, we do need you to come on. Right. If Sheikh Bimba is not able to,
okay, I'm here.
Yeah.
All right. Okay.
Right. Good evening, everyone, and thank you for this opportunity. I would like to remind all our listeners that it is very, very important listening to all the experts and professionals today that our communities, the Black and minority ethnic group, are mostly affected by this pandemic. And those who are using religion, I'm a sheikh and I'm imam, and I've had my own vaccine, and I will encourage everyone to have theirs. And one of our brothers as well, who is very popularly known in the world, Mufti Menk, he also has taken his vaccine. So those who say, oh, well, it is conspiracy theory. In Islam, Allah subhanahu wa ta'ala says, فَإِن جَاءَكُمْ فَاسِقٌ بِنَبَإٍ فَتَبَيَّنُوا. If anybody comes to you with an information, you need to verify. So those who are saying the vaccine is not true, we want them to bring proof, because the scientists have proven, like Mildred explained, how they focus to produce a vaccine within record time. And it's working. it's reducing hospitalization. And Dr. Kamara said that it doesn't stop the illness, but it prevents it. And we all know that for us to function properly as human beings, for us to give our all in our lives, to our loved ones, to our profession, to our careers, we need to have a sound mind, and a sound mind and a sound body. So it is an obligation in Islam that our Prophet Muhammad sallallahu alaihi wasallam told us that your body has a right upon you, just like all the organs of your body. So it is a duty that we take care of ourselves and our families. And the way we will do that is to follow the advice, the guidelines of the people who know. Allah subhanahu wa ta'ala says, is it equal those who know and those who do not know? And then he says in Surah Al-Baqarah, إِنَّمَا يَخْشَى اللَّهَ مِنْ عِبَادِهِ الْعُلَمَاء. Those who know are the people who are utmost to fear Allah subhanahu wa ta'ala. So once we have the knowledge, we need to use it to the best of our abilities. And this is prevention, and it's better than cure. So let us stop saying things that are not true. Let us help each other. Let us support each other. Let us know that it is going to rest on our consciences. If you do not take the right measure and you pass on this virus to someone and that person dies, it's going to rest on your conscience. And so a word for a wise is quite sufficient. So I want to thank everybody. I'm sorry I had so much difficulty with this technology, but I managed to download the Zoom again on my tablet, and that's why I've been able to come at the end. And thank you, everyone, and thank you very much to Mr. Morris. So with this, I will end and encourage all my listeners to take up the vaccine.
Thank you very much indeed. Thank you.
Thank you, Sheikh Bemba. I think now we go to Mr. Leslie Gibson to give us the vote of thanks.
Thank you, Alette. Again, let me start off by saying what a privilege it's been for me to have been able to witness such an informative and fantastic discussion amongst professionals in different aspects and areas of society. It's my hope that this discussion will bring a sense of clarity for people who, for one reason or another, are hesitant about taking the vaccine. What we witness is an unbiased discussion that is designed to inspire, educate, and help people reach a decision that will keep them safe from the coronavirus and enhance their well-being. We're keenly aware of the devastation that this virus has caused in our communities. We are also aware that there are deep distrust in many communities, but especially in the minority community. The discussion has been deep, frank, and honest. I must say this is what we need. All of us, I'm sure, in one way or the other, have heard the discussions or hesitancy towards taking the vaccine. Some of it has been out of genuine concern, and some has just been conspiracy theories at work. What we have witnessed are professionals who are dealing with the science involved with these vaccines and have based the discussion in a way to answer the questions honestly, to help us reach a comfortable conclusion and decision-making that will be beneficial for everyone. It has therefore been such an honor to have all of you that have participated in this event to make it a success. I would like to thank all of you for taking time from your busy schedules to participate in this program. The time you've dedicated to this endeavor has been priceless. It is my distinct pleasure to thank the following people. Ms. Sibella Ilong for her eloquent opening remarks to get the ball rolling. Our panelists, Dr. Mohammed S.I. Kamara, Emergency Medicine Consultant, Mrs. Mildred Johnson Bundu Kamara, Chief Pharmacist, Mr. Alpha Umaru Bari, Senior Research Nurse, Ms. Alimatu Demonican, women and girls' rights advocate, Dr. Ethan Harris Faulkner, general practitioner, and Sheikh Bemba Ibrahim Conte, Imam. Thank you for your in-depth science-based information. We learned a lot. For our guest speakers, Mr. Lamin Kosko Darami and Mr. Abdul Wahab Sise, aka DJ Little. And to you, our moderators, Ms. Aled Gobe and Dr. Ivan O'Brien, what a fantastic job you both did. And also supported by Ms. Fatou Gassamer and Mr. Maurice Koroma. And we cannot forget our folks that have worked in the background to make this event a success. Our broadcast media team via Zoom, YouTube, and Facebook, Mr. William Johnson Cole and Mr. Femi Palmer. Also, our flyers of Mr. Femi Palmer and Mr. Maurice Koroma. Finally, a huge thanks to our chairman, Mr. Victor Finney. The success of this event is a testament to your leadership. We thank you for your tireless work in the background to bring this program to fruition. Thank you all.
Thank you.
Thank you very much, Mr. Gibson. Thank you very much all. Thank you very much, everyone, because we've had such a wonderful evening and a very informative evening. And I mean, it's so lovely to see all the wonderful comments in the chat. I mean, it's been a wonderful day, and obviously we have much to be grateful about. We're thankful to our scientists, we're thankful to everyone, we're thankful to God, and we're thankful that we're here, that we can just say, thank God, that at least we're moving forward. We have a solution. And Alet?
I think you've said it all, Ivan. I'd like to thank the panelists once again, everyone behind the scenes, the audience for joining us with their questions, and most importantly, my colleague and co-host, Mr. Ivan O'Brien-Coker. Thank you very much. Stay safe, everyone.
Thank you very much.
So much. Thank you. Bye-bye.
Bye. Thank you very much indeed.
Bye.
Bye-bye now.
Yes, this not time for all Salon people and them party them. Sarah Media will be bringing you a variety of programs ranging from documentaries to discussions, interviews, news, views, sports, and entertainment. Our programs will contain matters on development, governance, the economy, and issues that are of importance to Sierra Leone. So, no left BNO because we get Bebe program then like Salon discussion, meets the ministers, the president's hour, and the Gladi program. Look me, I look you. All this they start soon. Now www.sarahjmedia.org. Now who's tem these?
As we talk about burning issues ranging from politics to the economy, culture to sport, education to entertainment, corruption to the environment, we realize the Sierra Leone story is family. So, Sierra Media Production brings you Zooming. Zooming In is the program that engages everyday people, entrepreneurs, inventors, entertainers, activists, policymakers, and politicians to discuss and debate issues related to Sierra Leone. Zooming In digs deep into the issues and stories. Zooming In ensures the debate is pushed to another level.
against
zooming in.
Some men harass and rape their women.
Some men sexually abuse.
Join me.
Some men beat their wives.
Any form of sexual assault is unacceptable. There must be consent before you act. Being in a relationship is not consent.
If they are not so
When I was young, a lot of things were different. Unfortunately, most of the differences seen now are heartbreaking and are not good at all.
Before now, men were strong protectors of the weak, fathers, brothers, lovers, sons. Their mere presence guaranteed the safety of women and children.
But what do we do now?
Men harassing and raping women.
Men sexually abuse little girls.
Men battering and killing their wives.
Any form of sexual assault, be it rape, sexual abuse, or pedophilia, is a killer to human self-esteem.
Women should stop dying in silence.
Speak now.
The rapist should be stigmatized, not the victim.
I think death sentence should be the consequence of such terrible acts.
And you mothers, build confidence in your children, put trust in them, listen to them when they make reports, and take necessary actions.
Talking of mothers before now, women were virtuous.
They were mothers, daughters, and sisters.
Nurturing, counseling, supporting their men folks.
But now,
women are trafficking female children for money.
Women are forced to be silenced.
All this must stop, and it must stop now.
Real men do not abuse, rape, or molest women and children. It is barbaric, unacceptable.
Let all real men stand with us.
Together, let's say an emphatic no to rape, sexual abuse, pedophilia, and domestic violence.